We're going to start talking about disorders of the vascular supply. I think it's funny how on page 465 of the book it says, please review the vascular supply of the nervous system covered in chapter 1. So it doesn't review it in there. But hey, if you want to, please review that. In the module here, I have included the vascular circulation of the brain with the posterior circulation, the 6 arteries that supply that. There's the diagram from page 465 on the book that's right here in the module as well. And it shows, the top picture shows deficits associated with loss of middle cerebral artery circulation, and the bottom picture is deficits associated with loss of anterior and posterior cerebral artery circulation. So we'll talk about some of those deficits specifically. So when we are talking about disorders of the vascular supply, we're really talking about loss of blood supply in a specific area. And the loss of function correlates with what specific area loses its blood supply. So a lot of times loss of blood supply in the brain is a stroke, but they're also episodes, they're classified according to the pattern of progression and the cause. So there's a transient ischemic attack, a TIA, which is a brief focal loss of brain function with full recovery from neurologic deficits within 24 hours. So what that is there's a clot that temporarily blocks off a cerebral artery, causing those neurologic deficits. And then the clot moves on or dissolves by itself, and you get full recovery. If the clot does not move on or dissolve by itself, then that will progress into a stroke. And there are 2 different kinds of strokes that we're going to differentiate here. A completed stroke, which is neurologic deficits from vascular disorders that persist more than 1 day and are stable. In other words, they're not changing. We're not getting increasing symptoms. And a progressive stroke are deficits that increase intermittently over time. So often a ischemic stroke, which is where we have blockage of arteries, usually by a clot, a thrombus or an embolus, are stable, and hemorrhagic strokes, which are caused by excessive bleeding, which could be an aneurysm or the rupture of an arterial venous formation, can be progressive. Ischemic stroke can be progressive as well if there are multiple clots in the system, but generally that's kind of how it goes. Sometimes with a hemorrhagic stroke, and we'll talk about this a little bit later, the deficits decrease over time as the excess blood in the area gets cleaned up by the body. So we'll talk about different types of stroke and different effects. So cerebrovascular accident, or CVA, is synonymous with stroke. Just like MI, myocardial infarction, is synonymous with heart attack, there are members of the medical community that are advocating the use of brain attack as a layman's term to replace stroke, to emphasize that prompt treatment may benefit some people who have strokes, just as prompt treatment is effective for some people who have heart attacks. So back in the early 80s, when I was working in the emergency room, people would come in with a stroke, and there really wasn't any acute treatment that we could do for them. There were no surgeries. They didn't have the TPA clot-busting drugs like they do now. There wasn't any imaging that could detect the stroke. And basically, they would admit the people to the hospital, monitor their vital function, and see what happened. Basically, try to keep them going. So consequently, people had much denser effects from the stroke and much more long-lasting effects. Now, if you get people in early as possible, they have those clot-busting drugs. They can actually surgically implant a stent into the cerebral arteries like they do with the coronary arteries, and decrease the effects of an ischemic stroke. There's imaging, CT scans and MRIs that they can use to focally pinpoint the area of the stroke. So there's a lot that can be done now, and the sooner people get in, the better. So the acronym for remembering how to tell if somebody's having a stroke is FAST, F-A-S-T. F is face, has their face changed? Is one side droopy? A is arms, can they lift both arms? When they have hemiplegia from a stroke, they can't lift one of their arms. S is speech, has their speech changed or is it slurred? And T stands for time. Time is of the essence. We want to get people in as soon as possible. So when someone is having a stroke, it's a brain attack, and we want to get them in fast. Face, arms, speech, and time. Okay? So a brain infarction is another name for an ischemic stroke. It occurs when an embolus or thrombus lodges in a vessel obstructing the blood flow. So that's directly analogous to a heart attack where an embolus or thrombus lodges in a coronary vessel obstructing the blood flow to the heart muscle. So, except this happens in the brain. Typically, an embolus abruptly deprives an area of blood, resulting in an almost immediate onset of deficits. So if say you're playing gin rummy with someone who has a stroke, you will notice immediately a change in them. They won't be able to talk, or their speech will be slurred. One side of their face might be droopy. They won't be able to hold up their cards with one side. So it's immediate. 1 second they're fine, and the next second they have deficits. So obstruction of blood flow in small, deep arteries results in what's called lacunar infarcts. Slow occlusion of an artery has a different outcome than abrupt occlusion. So slow occlusion of an artery can sometimes be like a TIA, where the clot is building up. And other times it can be like a quick onset stroke. So this is a chart from the book. It's also in the module, and it's also right here. So I put it in 3 places. That probably tells you that it's important. So what I want you to know from this pie chart, look at that big red area. This is ischemic strokes, and the incidence of ischemic strokes affecting each cerebral artery. 69%, a huge majority of strokes affect the middle cerebral artery, and we call those MCA strokes. So the stroke symptoms that we sort of consider typical, hemiplegia, communication difficulties or language difficulties, the homonymous hemianopsia, those are middle cerebral artery strokes most of the time. So you can see the other arteries, smaller percentages. We'll talk about the effects of each different artery, but I do want you to remember that most ischemic strokes affect the middle cerebral artery, and we get what we consider our stereotypical stroke symptoms. So in a hemorrhagic stroke, not only is there damage in the area where the bleed is, but downstream vessels are deprived of blood, and the extravascular blood, so the blood that's outside the veins, exerts pressure on the surrounding brain. So generally, this type results in the worst deficits within hours of onset, but then improvement occurs as the edema decreases and the extravascular blood is removed by the body. So with a hemorrhagic stroke, you often don't know what the long-term effects are going to be for a long time after the stroke. With an ischemic stroke, it's the progression's pretty typical. So a subarachnoid hemorrhage causes a sudden excruciating headache with often a brief loss of consciousness, brief meaning about a few minutes. The initial findings are often not focal, meaning it's spread throughout the subarachnoid space, that hemorrhage, that bleeding. Deficits are progressive because of the continued bleeding or secondary hydrocephalus. So it causes hydrocephalus because it bungs up the CSF flow, basically. So now we've got this extra blood in here. We can't, the CSF can't flow the way it normally does, and it causes problems. So you can get that secondary hydrocephalus. Vasospasm and infarction are common sequelae, and that's just because of the changes in the circulatory system. So we'll talk about stroke signs and symptoms by arterial location. I have slides in the PowerPoint of each different artery, but I also have a nice compressed little chart in the module, which is basically in a nutshell what I want you to know for the exam. So strokes may involve main arteries, smaller branches, the capillary network, or arteriovenous formations. So any of those vascular features can be affected in a stroke. So the vertebral and basilar arteries are in the posterior part of the brain. 20% of ischemic strokes affect the brainstem and cerebellar regions, because we know the cerebellum and the brainstem are in that posterior inferior position in the brain. The chief symptoms of a vertebral artery dissection, where the artery breaks open, is usually pain in the posterior neck or back of the head, occiput, and spreading to the shoulders. The vertebro-basilar artery, when you have an ischemic stroke, the most common signs are gait and limb ataxia because it affects the cerebellum. Limb weakness and oculomotor palsies and oropharyngeal dysfunction, those are cranial nerve functions which are in the brainstem. So areas of the brainstem and cerebellum are affected by these vertebral basilar arteries, and the symptoms go along with that. Totally makes sense. It's crazy how much sense it makes. So the most common symptoms in acute cerebellar infarction are dizziness or vertigo and inability to sit upright without support, because remember, our cerebellum is trying to keep us balanced and adjusting our movements. Difficulty walking, nausea and vomiting, dysarthria, which is difficulty speaking, and headache. So it can cause death, complete occlusion of the basilar artery, because ischemia of the brainstem nuclei control vital function, so it could cause death. Partial occlusions of the basilar artery can also cause tetraplegia, loss of sensation, coma, and cranial nerve signs. Severe partial occlusion causes locked-in syndrome, which is where nothing moves, loss of sensation, you're locked into a position. Not good. So cerebral arteries, the anterior middle cerebral artery, I'm going to switch over to the chart in the module because I think it's more straightforward. So this is the disorders of the vascular supply, just the definition and description of the ones we talked about in the PowerPoint, hemorrhage versus infarct. So these are the different arteries. So what I want you to notice with the arteries is the commonality and the differences between the signs. So we talked about the vertebral and basilar arteries. We get gait and limb ataxia because it affects the cerebellum and limb weakness. We get ocular motor and oropharyngeal dysfunction because it affects the cranial nerves coming off the brainstem. With cerebral arteries, all of them, middle, anterior, and posterior, have contralateral hemiplegia or hemiparesis. A lot of them have hemisensory loss. Different ones can affect different areas, but a lot of times you get that hemisensory loss. The hallmark symptoms for middle cerebral artery are language impairment and homonymous hemianopsia. Those don't show up with the other things. So if I said someone had a stroke, these are their symptoms, blah, 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 and they included language impairment or homonymous hemianopsia, you know it's a middle cerebral artery stroke. If I said it included personality changes, that affects the frontal lobe, it is the anterior cerebral artery. We still have the contralateral hemiplegia and the hemisensory loss, but those personality changes are a hallmark symptom for anterior cerebral artery stroke. With a posterior cerebral artery, we have contralateral hemiparesis and cortical blindness because it affects the occipital lobe. Posterior, it's occipital. And sometimes memory loss, which is when the temporal lobe is affected, and severe pain. So cortical blindness is a hallmark symptom for posterior cerebral artery. You're not going to see that with MCA or ACA strokes. You're only going to see that with the PCA stroke. Same thing with language impairment. You're only going to see that with the middle cerebral artery stroke. And the personality changes come with the anterior cerebral artery stroke. So I want you to know those hallmark symptoms. That I want, the common symptoms, contralateral hemiplegia and hemisensory loss, all of them have that. But those hallmark ones that tell you where it's affected. So the middle cerebral artery affecting language impairment, that's affecting those language centers in the middle of the brain. Anterior cerebral artery personality changes affect the frontal lobe. That's our personality area. And the posterior cerebral artery can affect the occipital lobe, and that's our vision area. So those hallmark symptoms, I want you to be able to identify which artery is affected based on those hallmark symptoms. And then with the vertebral and vascular arteries, it's those cerebellar and brainstem symptoms. So we in that cerebellum and brainstem chapter, we looked at the symptoms of cerebellar dysfunction and brainstem dysfunction, and here they are again in the guise of a stroke. Very interesting. So here's that pie chart that I love so much. Just remember, the big red area, 70%, well 69, is the middle cerebral artery, most common artery affected in ischemic stroke. And ischemic strokes far outnumber hemorrhagic strokes. So back to the PowerPoint, the cerebral arteries, we went over the information there. There is this lovely chart in the book that I also included in the PowerPoint. And the thing I like about it, I certainly don't expect you to memorize it, but the thing I like about it is it separates the signs into somatosensory, motor, special senses and autonomic function, emotions and behavior, cognition, language and memory, and other. And I just like that organization. It kind of helps tune things in to what you're seeing, and I really do like that. So take a look at that if you want to. Don't memorize it unless you want, and unless you're one of those people and you just want to do that. But you won't have to do it for the test, I'll tell you that. The blood-brain barrier, or the BBB, not to be confused with the Better Business Bureau, it's a specialized permeable barrier between the capillary endothelium of the central nervous system and the extracellular space. It's formed by tight junctions between the capillary endothelial cells that exclude large molecules like bacteria or big protein complexes or medications. The exclusion is useful for preventing many pathogens from entering the central nervous system. We want to keep pathogens out of our brain. Totally makes sense. It also prevents certain drugs and protein antibodies. So antibodies are big old proteins that are huge, and it prevents them from getting to the brain. Obviously some still get in, but we'll talk about the leaky areas in a minute. So when pharmacologists are trying to come up with drugs that affect the central nervous system, they have to take the blood-brain barrier into account. How are they going to deliver that medication and have it be able to cross the blood-brain barrier? So that is a concern. There is an anti-spasticity drug that's called baclofen that's often given to people, a lot of different things, people after strokes, people that have CP. But the problem is, for a lot of people, in order to give it in a big enough oral dose to have an effect and get enough through the blood-brain barrier, they have to take huge doses and it makes them sleepy. So it kind of, the side effects are too much in order to get a good effect. So one of the ways they deliver it, they actually implant an intrathecal baclofen pump, the thecal sac around the spinal cord. So they can put much smaller amounts of the drug because they're putting it directly into the central nervous system. So it's an implant, and it's controlled. It can be controlled externally and adjusted, and it puts a tiny amount of baclofen, not enough to make people sleepy, but enough to make them to affect their spasticity in a positive way. So really interesting new approaches to getting drugs across the blood-brain barrier in a safe manner. So the blood-brain barrier is absent in areas of the brain that directly sample the contents of the blood or secrete into the bloodstream. So that includes part of the hypothalamus and other specialized areas around the third and fourth ventricles. So the hypothalamus exerts a lot of its control through hormones and affecting other adrenal glands and other hormonal glands. So it needs to secrete things directly into the bloodstream. So the blood-brain barrier is considered leaky in those regions. And there are specialized cells that separate the leaky regions from the rest of the brain to prevent proteins, viruses, and some drugs from entering the brain via the leaky regions. So really interesting area and really interesting protection for our brain. So the cerebrum really requires a lot of oxygen. So when you go from the brainstem to the cerebral cortex, oxygen consumption increases a lot. So unfortunately, that leaves the cerebral cortex more vulnerable to hypoxia than vital centers in the lower brainstem. So sometimes when people are affected by hypoxia for whatever reason, their brain is deprived of oxygen, the vital centers in the lower brainstem still work to keep you alive, but the cerebral cortex is affected because it's more vulnerable to that. So cerebral arteries actually auto-regulate local blood flow, primarily depending on blood pressure and metabolites. The auto-regulation is hugely important to ensure adequate blood flow and prevent brain edema. So you want enough blood, but not too much. That makes sense, right? So cerebral edema is accumulation of excess tissue fluid in the brain. So when we have localized edema in another part of the body, that happens all the time, right? You bump into the table and you get a little swelling there. You get that localized edema. If you have that in your brain, that is a problem because it can put pressure on areas that you need. And it can cause areas of the cerebral cortex become hypoxic from that excess pressure. So causes of cerebral edema include concussion, because the trauma allows fluid to leak from damaged capillaries into the extracellular space. Cardiac arrest, because it messes up with that auto-regulation. And high altitude. Differing fluid pressure results in ischemia, causing arterioles to dilate, and increasing the capillary pressure and producing more edema in the brain. So you can have effects from cerebral edema at high altitude. So next time you go to Tibet or South America, be careful. So cerebral edema, hydrocephalus, tumors, and other lesions can cause increases in intracranial pressure. Usually symptoms of increased intracranial pressure include vomiting and nausea, headache, drowsiness, frontal lobe gait ataxia, which is another type of gait ataxia, and visual and eye movement problems. So lesions might produce a herniation in part of the brain. So another dangerous thing that you want to avoid. And all of those things, cerebral edema, hydrocephalus tumors, and other types of lesions can cause that increase in intracranial pressure. So a lot of times surgery is required to relieve that pressure.